I'm joined tonight with Kimberly Prislek, who's the Director of Clinical Services in our New York offices. We're honored to have you join us this evening. There's quite a few people signed up for the webinar. We've got a lot of information here as well. So probably a bit too much information. I got enthusiastic, and I don't know how much time we're going to have at the end for the Q&A, but I want everybody to type in their questions. We will try to answer if we have time. Otherwise, anything that's typed in by the end of the webinar, we're going to actually answer and then return answers to everybody who has signed up. So if we don't have time at the end, which I think there's probably a good chance we may not have much time to do many questions, we will answer them if you've typed the questions in before the end of the webinar, and we will get back to everybody via email if we're unable to answer them during the time allotted today. We're covering a lot of information. Kim and I both went to the American Academy of Dermatology yearly conference in San Diego. There was a lot about hair, a lot of new things that are coming up. We want to talk about those. I think it's really exciting. I think there's a lot of opportunity for new treatments coming up, and we want to just introduce you to some of those treatments, at least in a brief way. Hopefully we'll have more information as time goes on. So I'm going to go ahead and start. I'm going to take my picture away so that you can see the entire screen. We'll catch up again at the end. So again, thank you for joining us. This is what's new in the treatment of female hair loss. Kimberly and I are both excited to share our information with you. Maybe. Okay, sorry about that. I'm not technologically very adept here. So this is a brief table of contents of the things they're going to touch on tonight. There's a lot here. There's more information out there. I'm not going to give you too many references, but there are references available for pretty much everything that I'm talking about and Kim's talking about tonight. So if someone has specific interests in a particular topic and you'd like specific references, please let and I can get those back to you. So I just want to give a brief introduction about the hair life cycle. There's probably many of you who have been to other of our webinars and we touch on this, but there are probably new people as well. And I just want to make sure everybody understands the terminology that we're talking about. This is the hair life cycle. There's 3 parts to the cycle of hair growth. The anagen is the actual growth phase, which can last anywhere up to 6 years. It tends to shorten with age, but it also shortens with some of the causes of hair loss, and we'll talk about that. The catagen is the phase where the hair starts to pull away from the follicle, where the root starts to pull away and it starts to loosen up. That can last up a couple of weeks. And then the telogen phase is the beginning of when the hair actually falls out. So those are 3 important terms to remember. The telogen phase can last anywhere from 3 to 4 months before new hair starts to grow back. Okay, female hair loss risk factors. These are important, and this is where some of the newer information comes from. The genetic piece is huge, and as it turns out, it's not just the androgenic or the typical genetic hair loss where we get concerned about someone's hereditary makeup. We are now seeing more information about scarring alopecias and alopecia areata also having some genetic components to it. So that's exciting in that it may offer new treatments in the future. We do know that stress plays a huge role in hair loss. I don't care what the diagnosis is, stress plays a huge loss across the board. It's a tough term. It's a tough problem to manage. If this is something that interests you, I actually did a webinar last fall on the effects of stress and hair loss. Feel free to look that up if that interests you. Poor nutrition, we can't talk about this enough. Again, we've had other webinars on this, and we do know that the diet, particularly in this country, is incredibly poor and very pro-inflammatory, which can lead to further loss. The nutrients in our diet are very limited. and most of us can benefit from some kind of supplementation. I'm not going to spend a lot of time talking about supplements. We didn't hear a lot about the supplements at the conference. There is certainly information out there that good nutrition and supplements do have benefit, but more research needs to be done. We've done our own here, and certainly they do help. Illness can play a role. Other types of illnesses, chronic illness, can play a role in hair loss, particularly telogen effluvium, but the other causes as well. Hormonal imbalances, important across the board. Again, not just androgenic alopecia, but hormonal imbalances can play a role, and the medications treated, particularly for scarring alopecias, do involve hormonal treatments. Age, we do know that as we age, hair thins out naturally, but that doesn't mean everybody's going to get alopecia as a result of just aging. Scalp and follicle health is something that was discussed at the conference as well. We will touch on that as well. Okay, again, I just want you to know the terminology. We're not going to talk a lot about these, but I do want you to know the terminology, because the treatments we're going to talk about are for these specific diagnoses. So non-scarring alopecias include the androgenic alopecia, which is the majority of what we see. It's about 80% of what we see here at Meditress. Telogen effluvium is excessive shedding. Traction alopecia is hair loss as a result of pulling and tugging and harsh hair care practices. Alopecia areata are spots, and sometimes you can lead to complete loss of scalp hair and body hair. We do see a fair amount of post-cancer hair loss, and we do offer treatments for that. I just want to say the androgenic alopecia is the most common. It has a genetic component to it, does have a hormonal component to it, and it is by far the most common cause of hair loss in women. Non-scarring means that it's generally not considered permanent. The follicle does not get destroyed, and so treatment that is started early can have significant improvements. Scarring alopecias, on the other hand, are inflammatory. They're often autoimmune disorders, where unfortunately, if it's not treated early enough, the follicle does get destroyed, and it's harder to get regrowth. We can stop the loss, but it is harder to get regrowth, although newer treatments are becoming more hopeful. The most common types are frontal fibrosing alopecia, centrifugal cicatricial alopecia, that's a mouthful, lichen planopilaris, and those are the abbreviations you might see: frontal fibrosing, FFA, CCCA, and LPP. Okay, again, important for us to let you know, you can't get the proper treatment for your hair loss unless you get a good, thorough evaluation. And I need to let you know that this, what we're telling you tonight is not meant for you to go out and start treatment. It's also meant to encourage you to get the proper treatment by getting a full evaluation, physical exam, hair loss history, examination of the scalp via trichoscopy, blood work, sometimes a biopsy. That's really what's needed before we can make a decision about what the best treatment is for you. Okay, let's talk about updates in androgenic alopecia. There's not a lot of new information about causes. We know it is genetically predestined. We do know hormones play a role. It's interesting. We're doing more and more biopsies because we're seeing more scarring alopecias, and we'll talk about that later. And as a result of seeing more and more biopsies being done, we're seeing more and more microinflammation and some fibrosis, which is scarring, noted even on the androgenic alopecia patients. It's mild, but again, some studies up to 70% of patients who have biopsies that do have primarily androgenic alopecia will have some degree of inflammation. And I think it speaks for what our environment and our diet does to our bodies in general, and the hair in particular. There's a moderate amount of evidence to suggest that decreased circulation and vasoconstriction, or tightening of the blood vessels, also may play a role. Some of the medications treat that, particularly minoxidil and laser therapy for androgenic alopecia also do help with the decreased circulation that can take place with androgenic alopecia. Nutritional deficiencies, again, I go into specifics, but these particular ones, vitamin D, zinc, the B vitamins, and iron, are particularly important for good hair health. Here at Meditress, we did our own study. We found people who took just supplements for 6 months and have improvement in their hair growth. And again, I think it speaks again to the quality of the diet that many of us have. We do some nutritional counseling here. We're not dietitians by any means, but we know the importance of good nutrition, and particularly the anti-inflammatory diet is really important. but these particular nutrients are exceptionally important. And we do test for these when people come in. We do blood work. We make sure their nutritional status is adequate. Hyperandrogenism, which just means too much testosterone in your body. Women have testosterone as well as men. We don't nearly have as much as the men do. But there is a syndrome called PCOS, which young women have too much testosterone. There's a wide spectrum of PCOS. Not everybody has all of these particular symptoms associated with it, but hair loss is a prominent feature of this. And that's why when young women come in and they're having hair loss at a young age, we always test testosterone levels. Older women can have slightly elevated levels of testosterone and androgens, but it's not to the same degree as to what we see in young women. And it can play a very significant role. Telogen effluvium is excessive shedding, and we see this unrelated to androgenic alopecia all the time. It generally can be a temporary shedding of hair due to a shock to your system, whether it's pregnancy, illness, surgery, something happened. Stress plays a huge role here. And the shedding occurs about 2 to 4 months after the event. We saw this a lot with COVID. Most women will experience complete regrowth in a year, but what we have begun to realize is that a telogen effluvium can often be a precursor to androgenic alopecia, and it can also unmask it. So a woman can have a profound shedding episode unrelated to the androgenic, and yet when the telogen effluvium and the shedding resolves, what we can see on trichoscopy on the microscopic evaluation is evidence of androgenic alopecia. So it just brings it to the forefront. It makes it more obvious. And again, I just want to touch on this. Again, the 3 cycles in the hair life cycles, the anagen is the growth phase. And what we see with androgenic alopecia is that the growth phase, the anagen phase, decreases. And treatment addresses that. Minoxidil, laser, some of the medications will help prolong that growth phase. But the interesting part of what research has recently found is that the decrease in this growth phase, the decrease in the anagen growth phase, can occur even before the increased shedding occurs, or the miniaturization, which is the shrinking of the follicle and the shrinking of the hair. So early on in particular, but even later, the goal of treatment has to include prolonging that anagen phase. And again, laser, minoxidil, and some medications are good in that. And it's, a lot of women are hesitant in terms of medication, but I think that particularly laser and minoxidil, you have to give some serious thought to that, because prolonging that growth phase is critical to improving hair loss secondary to androgenic alopecia. So again, what do we recommend? What do we recommend for topical treatments? So first and foremost, I'm going to talk about minoxidil, and a lot of people groan when I say this, but it's been around a long time. I think it's gotten a bad rep, but I think the bad rep comes because people expect too much of it. Minoxidil does cause a little bit of hair shedding in the beginning for about a month, but improvement in hair counts and hair widths and density is pretty much noted in 6 to 12 months. And the prolonged anagen phase is now present. So it does help. It's not going to make you look in the mirror in 6 months and go, oh my gosh, all my hair is back. It looks so much better. But if you were involved in a study, you would have measurable improvements, and it's definitely worth considering. And we do still offer it topically, primarily the 5%. Now, what can increase the absorption of minoxidil? It's important to know this. Twice daily application does increase the treatment. For a woman, I think it's hard to do. I use minoxidil. I do it once a day at nighttime. To add it twice a day, I think is asking a bit, but it's important that the 5% is used and not the 2%. If you add topical tretinoin to it, which is another medication, it does improve absorption. We have our formulated minoxidil here at MediTrust, and we do add the tretinoin to it because it does improve absorption and it does improve benefit. When people do some microneedling, which is another treatment that some people do for androgenic alopecia, it does increase absorption. What can decrease the absorption? It's important that if you're going to use minoxidil, you need to make sure you're not doing things that are going to get in the way of it working properly. One is if you're using topical steroids, it will decrease the absorption. Now there's a caveat to that because there are some types of hair loss like like alopecia areata and scarring alopecias that require topical steroids. And we understand that. And we still do recommend minoxidil. So the steroid does minimize the absorption a little bit, but we still do recommend the minoxidil. Now, shampooing within 4 hours will wash out the minoxidil. You have to let it sit there for at least 4 hours. I put it on at night, wash it out in the morning. That's perfect timing. If you have your scalp covered in any way, if there's hair fiber applications, it will get in the way of the minoxidil absorption. Again, hair fibers are fine, but it can't be just before you put the minoxidil on. Also important to know, the foam does work. The 5% foam does work. It's less irritating than over-the-counter minoxidil, but it's not absorbed as well. I'm still a proponent of minoxidil. So what other things can be utilized topically? Well, finasteride, dutasteride, those are testosterone blockers. They can be used topical and they can be formulated to be given topically, which is good because not everybody wants to take it orally. Metformin is a new player in this game, and we'll talk a little bit about that. Metformin is typically known as a diabetes medication. It's a metabolism treatment medication, and there may be some benefit for androgenic alopecia and also some of the scarring. We'll talk a little bit about that. It's sort of something new in the horizon. There's actually a conference next week I'm going to try to listen into where they talk about these treatments. Here's a new one, KX826. They won't even give it a name. It's very close to being released. It's a new topical anti-androgen that's being studied, and hopefully it'll just be another thing we can add. Clascoterone is actually an anti-androgen cream, which is used with a lot of teenagers for acne. It is being studied now because it does have that anti-androgen benefit. Unfortunately, I think a cream is not practical. They're trying to find a solution that may be useful. It's being studied, and again, it may be something we could add to the list. Rosemary oil, it's not 2%. That's actually a typo, so forgive me on that one. But rosemary oil is a hot topic. And is it worth using? Well, it's not as good as minoxidil, and it can be an irritant for many women. One study did show that it was as effective as 2% minoxidil, but we don't recommend 2% minoxidil for anybody. It's not strong enough. It doesn't have enough benefit. So rosemary oil sometimes can improve some growth. It can actually be some anti-inflammatory. It does have some benefit there, but I don't think it's strong enough for a treatment for androgenic alopecia. It is not as good as minoxidil. Ketoconazole is 2%. That is a shampoo, which comes 1% over the counter as Nizoral brand name, but 2% is the prescription strength. It is a shampoo that is used actually for seborrhea or dandruff, but it has been shown it has strong anti-androgen benefits, and it has been shown in studies to improve hair counts. I use it once a week, not as a dandruff medication, but as an anti-androgen shampoo. It's a shampoo that actually can dry your hair out a moderate amount. So if you're going to use it, you need to use a good conditioner, a good cream conditioner afterwards. Okay, let's talk about oral medications. Okay, I'm just checking my time here. We're covering a lot of topics here. So oral medications. I want to talk about low-dose oral minoxidil. We talked a little bit about this last year. It's getting more and more press these days for a good reason. It does have benefit. There's no question. Oral minoxidil does have benefit. And for women who either don't like how topical minoxidil or other topicals make their hair feel, or if they have scalp irritation, they don't tolerate the topical treatments, and there are many women who cannot, then the alternative is low-dose oral minoxidil. And so low doses, I can't stress that enough. In women, the doses we start at 0.625 milligrams, go to a max of 2.5 milligrams. It's incredibly low. When we used to use this medication for hypertension, we would use doses on the order of 20 to 100 milligrams a day. So we're talking very low dose. So it does have benefit. There's a little bit of argument over whether it's better than the topical. I think in some cases it is. I do. But again, it depends on how reliable you are in taking your medication. So what are the risk factors? It does have some cardiovascular risk factors, but they're rare. They're very rare. They can happen. Palpitations can occur, a little bit of fluid around the ankles. And patients who have underlying heart disease, we do not recommend low-dose oral minoxidil. We just don't. I would prefer to have them use topical, and most of their primary care physicians would agree to that. The most common side effect to oral low-dose minoxidil is hirsutism, which is too much body hair. And I try to encourage my patients to stick with it, because if it's growing hair elsewhere, it's growing it on your head as well. And I think that's a fair statement. And most patients, it's treatable very easily, but it is the main reason people will discontinue low-dose oral minoxidil, but it's less than 5% of patients. Okay, talking about spironolactone, this is a medication that's been around for a long time for hair loss, and it does help androgenic alopecia. It is a testosterone blocker. It blocks the DHT, which is the form of testosterone that actually binds to the follicle and causes it to shrink up. It increases the conversion of testosterone to estradiol. It's particularly effective in younger women, because younger women have higher levels of testosterone, and they need that treated if you're going to treat the androgenic effects of their hair loss. So what's new about spironolactone? It's been around forever. We use typically in women younger than 50, we start 50 to 100 milligrams and max out at 200 milligrams a day. It is a diuretic, and usually for the first few weeks, it does cause you to urinate more frequently, and that can be problematic for some women. I tend to not use it as much for older women, and I haven't until recently, because not only does it act as a diuretic, but it also can alter your body chemistries, your potassium, your sodium. It can dry you out a bit. So I tend to stay away from it in women, particularly over the age of 60. But there were a couple studies recently published, and I was glad to see these, that in women over the age of 50, that even less than 75 milligrams, 50 to 75 milligrams of spironolactone does seem to have some benefit. So I was pleased to see that, and I'm more inclined to use it in older patients with a lower dose. Still need to be careful about the potassium in our older patients in particular. Okay, let's talk about finasteride and dutasteride. Some of you have heard of this. There are a lot of questions about it. It comes in the category of 5-alpha reductase inhibitors. What does that mean? It means it blocks the testosterone effects at the level of the hair follicle. Men have been using it for decades. They actually, despite the fact that having a higher dose of testosterone, they get away with a much lower dose of the finasteride, 1 milligram of finasteride and 0.5 milligrams of dutasteride. Interestingly enough, the initial studies in women for these medications didn't show much benefit, because they were using the same doses that the men used. And over the course of the last 10 years, the dose have been increased to 2.5 to start, to 5 milligrams max out for finasteride in women. And it does seem to have benefit in about 50% of the time. It's not considered a standalone treatment. It's an additive treatment for androgenic alopecia. Interestingly enough, it's also used for some scarring alopecias, particularly the CCCA. It's unclear what the hormonal reason is for this, because these women do not have elevated testosterone, but it does seem to help in those instances. Very important fact, in postmenopausal women, it's well known that an increase in an unopposed estrogen is a risk factor for breast cancer and uterine cancer. We do know that finasteride in women can drop those estrogen levels a little bit. And so we don't want the testosterone, we don't want the estrogen. It causes it to increase. I apologize. It causes the estrogen to increase, and we don't want that to happen in women who are at risk for breast and uterine cancer. If you have no family history, it's not a problem. If you're not a carrier of the breast cancer gene, not a problem. But in some women, we would not use these medications. Even spironolactone can be a bit of an issue here. So again, I apologize. I stated the wrong thing. It actually can, it drops the testosterone, but it does increase the estrogen to a limited extent, but it can. And so for those women who are at risk for breast cancer and uterine cancer due to their genetics or their own personal history, we would not use these medications. So I apologize for the confusion there. Okay, again, other side effects to these medicines include breast tenderness. It can cause depression in some very sensitive women, but primarily in women who already have a history of depression. And it can cause some liver issues. So if you have a liver history of liver disease, we wouldn't use it. I want to talk about low-level laser therapy, because for a long time, a lot of people didn't believe that it worked. It wasn't recommended by a lot of dermatologists out there. But the reality is that it does work. And there's more and more research to show that it does work. There will be a slide that shows you how it worked. But, initially, I want to talk about the low-level laser therapy with LEDs. That's something that has been coming out over the last few years. Initially, all laser therapies, home treatments, had just laser diodes in them. And it varied anywhere from 10 to 300 different laser diodes, depending on the model. Recently, they've become with a combination of laser diodes and LED lights. And so, I started asking questions. What is the deal with the LEDs? Do they work as well? Do they still help control inflammation and stimulate growth? Do they improve circulation? I was unable to find any real-time studies that compared the assorted styles and combination of light sources. Does one work better than the other? That's still a big question mark. And they all work, though. I will tell you, across the board, laser therapy does work for androgenic alopecia, and there's more evidence to suggest that it's also working for scarring alopecia. In terms of the difference between laser diodes versus LEDs, the laser diodes are known to be a stronger and a more focused light source. The LED is more splayed and it's not as strong. I will tell you that I don't recommend any quote unquote laser cap that is only LEDs. There have to be laser diodes in there. If there's a few LEDs, I don't think it's a huge deal, but I think honestly, all the research that's been done has been primarily on just laser diodes. And until that changes, that's pretty much all I'm going to recommend at this point. So again, unable to find any studies also demonstrating how the LEDs work as opposed to the laser diodes, which have had many, many studies to show how it worked. LEDs probably have some benefit, but I don't believe it works as well as the laser diodes. Okay, so, we lost our picture here. The light is absorbed within the cell, and it actually increases oxygen levels and energy levels within the mitochondria, which is this organ within the cells. We used to have a nice little picture here, but for some reason it didn't stick. Anyway, it does increase mitochondrial activity in the dermal papilla, which is where the hair follicles make the hair. And we know that this activity is decreased in people that have androgenic alopecia. So increasing it is very important. Low-level laser therapy does prolong the anagen phase. We talked about that before. It stimulates the telogen phases in the follicles to transition quickly into the anagen phase without the usual resting phase. And then it maintains a prolonged growth phase, which is so important because we know that's what happens in the early phases of androgenic alopecia. The growth phase shortens. So we need to prolong that growth phase to get better, healthier hair. We do know that it also increases hair strength. Studies have shown that. It decreases inflammation, which is so important because as you remember, those little biopsies that were done in androgenic alopecia, we're seeing more inflammation there. The importance of that isn't clear, but if we have a treatment that does decrease that inflammation, it's important. It accelerates wound healing, stimulates growth factor gene expression. All of that's important, does increase the blood flow. One study showed by 200%, which is remarkable. Again, we know the blood flow diminishes with androgenic early on. We need to increase that blood flow, decrease inflammation, prolong that growth phase, make the hair environment healthy as can be for hair growth. So again, I think I've often said that I believe every young woman, older woman, whatever age, can benefit from low-level laser therapy if you have androgenic alopecia. Again, it's not going to make you look in the mirror in 6 months and say, oh, I've gotten my old hair back. There's nothing that can do that, but there's no question that it's going to have benefit. The benefit is additive if you add minoxidil to this. In terms of other types of lasers, when people talk about lasers, they think about, you go to the dermatologist, you get things lasered off, or you have other types of laser treatments that are used for hundreds of different medicinal purposes. What I just talked to you about was low-level laser therapy, which is a cold laser. Recent studies have shown that the LLLT, the low-level laser therapy, can show benefit with alopecia areata and scarring alopecia. It does decrease inflammation, very important, and it does improve hair counts to a limited degree. But again, with scarring alopecias and alopecia areata, it's an inflammatory disorder. We've got to get that inflammation under control. Laser is an important way to do that. Should never be used as the standalone treatment for any of these problems. It's an additional treatment. It takes multiple types of therapy to grow your hair back regardless of the cause. And this is an important part of that. So let's talk about the other lasers. And there are many, many, and I'm not going to talk about them individually, but some of you may have heard of these. There's non-ablative versus ablative lasers. And so what does all that mean? And the ablative ones, the non-ablative ones actually push energy down. And we know that thermal energy causes an environment that is actually better for hair growth. Ablative lasers actually can cause microchannels, which allows some growth agents to travel into the dermal layer. And there are some benefits to that. So there are different types of lasers that accomplish different things. So what does that got to do with hair growth? Well, there are some preliminary studies which show that lasers, these type of lasers, and this is not low-level laser therapy, this is different, but that these type of laser treatments can increase hair growth across the board. These are preliminary studies, and I want to stress that. There's no standard in terms of the scheduling. There's no specific modality that seems to work better than others. There's a lot of experimenting going on with laser therapy and hair regrowth, and some do have benefit. It's interesting to see. There are new laser machines coming out that may have benefit. The laser treatments are often, but not always, combined with other types of treatments like topical minoxidil. Again, those microchannels can help the minoxidil be absorbed better. Sometimes they do PRP with injections after doing the laser therapy. They use topical growth factors, which unfortunately they don't clarify what they mean by growth factors in most of these studies, but this is something that in the future may have some benefit. But again, there's a lot of different lasers being used, a lot of different schedules, and a lot of different laser modalities. Side effects of laser therapy, it's not a cold laser. Some of them are ablative, which means it can cause a little bit of irritation on the top of the skin. And it can cause some burning and itching in very sensitive people, some erythema, redness, and some scaling. It's usually temporary, but it's not uncommon with laser therapy. I'm going to tell you about a couple of brand names because people come in and they ask us, well, what about this treatment or what about that treatment? How do they work? Do you offer them? So again, these are laser treatments, and many people have heard of them. Keralase is a very common one, and it's from a lutronic laser. They use what they call a growth factor on it to help it be absorbed. I don't really know what's in that growth factor. And it requires monthly treatments for 3 to 6 months and then follow-up treatments after. Same is true of the Luminous, which is a non-ablative laser. It's very new. Again, 3 to 6 months of monthly treatments followed by booster treatments. They do not add anything to their treatment. There is a laser-only treatment. The problem is, again, there's no consistent scheduling, there's no dosing, there's no studies comparing the different types of lasers. The treatment is indefinite, as is the case with all types of treatment for androgenic. There's no comparative studies with PRP, which to me is a bit surprising because PRP has decades worth of studies done with proven benefit. And before moving on to another new type of treatment, I'd like to know how it works in comparison. The other thing that's important is PRP is the only treatment that utilizes your own stem cells and your own growth factors. So whatever quote unquote growth factors they're adding in the Keralase treatment, they're not your own human growth factors. And so again, the bottom line is more studies need to be done. They need to clarify scheduling. They need to find out what the optimum dosing and additive treatments are to make this work best. I want to talk very briefly about the sonophoresis or the ultrasound. Again, that's a new treatment that's out. And so let me just get that. Oh, sorry, I went too fast. It is using acoustic sound waves and air pressure to deliver quote unquote growth agents. It can be used for other types of things like finasteride, minoxidil, stem cells, which again, you can't purchase any longer. And these are not your own that are being applied. Vitamins, amino acids, there are a variety of things that can be quote unquote pushed through the skin utilizing sonophoresis or ultrasound therapy. There's a new machine out called the Almated, which utilizes this ultrasound therapy. It's an assistive device that again uses a quote unquote proprietary topical hair care formula. What that means is they're not going to tell you what it is. they do the ultrasound, they use this formula, the ultrasound machine is able to push this formula into the area where it's needed to stimulate growth. I don't know what's in it. They won't tell us. It's not your own growth factors. It's not your own PRP. It's something that they have produced to go along with this treatment. It does require 3 monthly treatments and then boosters after that. Does it work? Yes, I think it does. Their studies do show some benefit. But again, I don't know how any of these treatments compare with PRP, which is, I consider, the standard right now. And it may be they could be utilized equally, but at this point, I can't tell you that they work as effectively. And that's the question that I get asked all the time. Do these work as well as PRP? And there's no answer to that. Okay, so both the laser and the ultrasound-based therapies, they can stimulate hair growth for androgenic alopecia. There are no studies for other types of hair loss. They do, however, often rely on a combination of topical solutions to be released onto the tissue, as well as thermal trauma to help stimulate growth. Important to understand, there are no FDA-approved human stem cells or exosomes that are available for ultrasound or laser therapy. They're not available. The FDA has taken them off the market. So whatever they're putting on your scalp with these treatments, they are not human stem cells. They are probably botanicals and some growth factors, which can help stimulate hair to grow and seem to have some benefit. But it's important to remember that PRP and OPC, which is the way we do PRP, is the only approved method presently to utilize your own stem cells, your own exosomes, which are super stem cells and growth factors. This is the only treatment that allows you to use those cells and growth factors to stimulate growth. So I want to just briefly tell you about jet peel, which is, again, another form of another machine which helps us do hair growth. And this is a little different because jet peel is a technology that is actually used for other types of treatments as well, but we utilize it for what we consider to be painless PRP. PRP most of the time is applied via injections. You utilize your own blood, you get the growth factors, you get the stem cells, you get the exosomes, and they are then injected to the level of the hair follicle to stimulate growth. This technology that we have available at Meditress, we've used for a few years now. We utilize a jet peel machine, which allows us to not need needles. It's non-invasive, it's needle-free, and it's pain-free. So how does that work? It sounds too good to be true, but the jet peel allows us to use patented high-velocity jet pressure energy to actually infuse your plasma and your platelets. And it creates microchannels to allow that PRP serum to be infused into the dermis layer without needles or pain. This is not a topical treatment. It's not something we just lay on the scalp and hope it gets absorbed. It's actually infused to the same level that the needles infuse PRP, but we do it without needles. We still offer standard treatment with the needles. It's still available. It is what most people are doing out there, but we do have this option of doing it painlessly. We do see significant improvements with this jet peel painless PRP. I will be honest and tell you, much like the other machines, there are no comparative studies with the standard needle treatments, but we have done thousands of them here, and we know that they work. Again, treatment for PRP, whether it's painless or with the needles, it's a 3 monthly treatments, once a month for 3 months, followed by boosters every 3 to 6 months. There is no cure for androgenic alopecia. You just have to keep treating it, and it's hard. And so the treatments are getting better at regrowing hair non-surgically. Used to be that there was nothing available other than minoxidil. So all of these treatments are improving. There are new treatments coming down the pike, and we're very hopeful. So I'm going to turn this over to Kim because she's going to talk about mesotherapy. It's something that interests her. So I'm going to turn this over to Kim, and I will manage the slides for her, if that's okay.
Thank you. Thank you for this opportunity. I'm going to go back one.
Sure. Oh, there we go. Is that good?
Yeah, perfect. Thank you. Mesotherapy, it's actually a local intradermal therapy. And it actually comes from the Greek word mesos, meaning middle, and therapy, meaning treatment. Just a little history. The insertion of needles to alleviate diseases has been around for a very long time. Hippocrates in 400 BC used the needles of a cactus to inject. The Chinese used acupuncture 2,000 years ago. And the injection of substances following the invention of the hollow needle has been happening since the early 19th century. So mesotherapy is basically a minimally invasive method that involves the injection of agents and drugs and bioactive substances. It can get to the depth of approximately 2 to 4 millimeters. When do we use it? Androgenic alopecia or pattern hair loss. I think that's been around, probably mostly studied of all of the alopecias, but I do feel it's going to go into the realm of the scarring alopecias hopefully soon. Patients who don't want to take oral anti-androgens, I think that's a very common question I get is, what else can I do if I don't take this? And I think our options are opening now. Patients who are apprehensive about oral medications, a lot of people want to be organic. They don't want to take something internally that can affect their entire system. Or if they presented it and they had side effects or at risk for side effects, I feel that these are patients that, this kind of therapy would be perfect for. Patients who require intensive treatments, I think in combination, whether we're on a low dose anti-androgen or we're doing PRP or we want to add minoxidil, we can add these and not have to do something every day. I feel that patient compliance is so important when it comes to hair. Hair loves consistency. If we're not consistent, I feel we do more harm. And in doing mesotherapy, I think we can kind of come down to where we're a little more consistent. How is it delivered? Typically, we use a 28 to 30 gauge needle, or we use a meso gun. Sessions last 15 to 30 minutes. Or we could go more towards the minimally invasive or the needleless procedure using our jet peel. The jet peel, and actually there's many different wands we can use with this type of machine. Basically, the jet peel is a pressurized mesotherapy. It's a needle-free method used that we can accelerate using a jet of air to insert the ingredients into the skin tissue. And I think this is a great way that we can maintain, less side effects and actually similar levels of drug penetration. This is a nice kind of a systematic review that aims at summarizing some of the current literature that evaluates the efficacy of these kind of techniques and overview of the study results. Mesotherapy has been studied in about 6 different classes of agents and many combinations, including minoxidil, dutasteride, growth factors, stem cells, peptides, multivitamins. Usually in combinations. I think in combos, you get a little more sophisticated. You can kind of make it more towards what you need and what kind of alopecia you have. So I think this is the future of treatments targeting the scalp. Things like minoxidil, I feel that, yes, it's FDA approved. It prolongs anagen phase. It treats pattern hair loss. Mesotherapy has been used where you can use 0.5 to 2% administer weekly. But now they're coming up with more studies that are looking at monthly or bi-monthly, increases the therapeutic effect. Basically, when you're targeting a miniaturized hair, you're getting the medication right to it. And I think that that's what the future of, mesotherapy, but also therapies in general, targeting what we need to. Also, the side effects of minoxidil, very minimal systemic involvement. So I feel that it's very, it's safe. Growth factors, super important for hair. We all know that a lot of growth factors it takes to grow hair. We use our own in PRP. But if you want to go towards the synthetic growth factors, the fibroblasts, the endothelial, the epidermal growth factors, they're all very important for regeneration. Adding a growth factor to minoxidil would be a great way of providing therapy. Although the problem is not a lot of standardized studies and dosings at this time. Meso solutions, You see a lot of these peptides, vitamins, amino acids, plant extracts, a lot more homeopathic components. Administration of these, I think, can definitely induce, some increased blood flow. It stimulates the hair growth. Again, not a lot of studies and allow a lot of consistency in these studies. Mesotherapy, this is where I feel mesotherapy can play a major role. And I really like to talk a little bit. I know we discussed, Dr. Wendell did an excellent job discussing dutasteride and finasteride, but I want to go a little more in depth in the difference. Finasteride is a 5-alpha reductase inhibitor. It blocks type 2 isoforms of the enzyme that converts testosterone to DHT. And we all know that that testosterone to DHT cycle is a killer for our hair. Now, finasteride was one of the first on the market. Dutasteride has come over the past few years, but it's more potent, a 5-alpha reductase inhibitor. It blocks type 1 and type 2 isoforms that converts the testosterone to DHT. It has a much longer half-life, and I think this makes it uniquely suited for localized mesotherapy. My thoughts about what's new on the horizon when it comes to anti-androgens, I feel that the future will be not blocking the testosterone to DHT, is to actually block the receptor of the DHT on the follicle. I feel that the future of hair loss will somehow be related to this and targeting just the hair. I do believe that this has to become part of what we do. But a lot of studies out there happening, and I do believe that we're going to be doing more targeted treatments. This was a very nice study. It looked at monotherapy with mesotherapy with dutasteride, but I'm going to be focusing more on the monotherapy aspect of this study. It was 540 patients, 71% or 387 were females. Males were 154. So finally, a study really making females the dominant study. Actually, what I really liked about this was they looked at dutasteride. They looked at dutasteride with combination therapies, but they looked at dutasteride with mesotherapy. And this was every 3 months. The dutasteride was injected sterilely at 0.025. It had great effectiveness. 86% showed improvement. 38% stated they had marked improvement as a monotherapy. The adverse effects of this, 45% stated they had discomfort, but there was no serious or systemic adverse effects. So I feel that this was a large cohort sample. The only negativity about this study was that there was no control group. So there was no group that got no therapy at all, and there was no comparisons between the two. But I feel that this is a start for us in the hair field. I feel that there's definitely a lot of studies looking at mesotherapy, more targeting the hair. Mesotherapy with bicalutamide and the other anti-androgen flutamide, I think there's a lot of research looking at this. The procedure is similar to dutasteride. It's safe in women. There's no systemic side effects. Can be used in other treatments. Some patients also saw improvement of their scalp health, but I think that there needs to be a little bit more studies on standardizing the treatment regimen. So what are the advantages and disadvantages? The advantages are we're directly administering these agents into the skin by bypassing the barriers that we are faced when we use topicals. I think when we use topicals over time, there is this thought of dermal fatigue. Like your skin over time, you lose elasticity, the blood flow changes. And I feel that if you use a topical for an extended period of time, the actual absorption may change. And I think that mesotherapy is giving us this kind of edge to where we can administer a drug. You've got to do it maybe once every 3 months. I mean, that's acceptable for a lot of women, I feel, and targeting, the treatment. intradermal injections, they can increase the residence time of a lot of these agents into the affected area, the miniaturized hairs, allowing them, you can use lower doses and longer durations between sessions. And I think that's where we're going with mesotherapy. Some of the disadvantages, uh, even though studies, a lot of the studies that I read, they all show some statistically significant improvements in the hair after the treatment, although there's no standardized regimens. And I feel that that's where we're headed towards now. I believe that mesotherapy can lead to improved treatment outcomes and definitely patient compliance. A lot of treatments, minimally invasive procedures, they are definitely promising options for today's female with hair loss.
Thank you, Kim. That
Thank
actually
you.
is really interesting potential treatment as we move forward. Thank you. I actually want to just address a couple issues of that patients bring up with me in terms of PRP and what the benefits are. And there's a lot of misinformation out there, and I'm just going to touch on a few topics quickly because we're actually running a little bit behind. But PRP is platelet-rich plasma, and it's your own plasma, and around the platelets that circulate in your bloodstreams, there are up to 800 bioactive molecules that are secreted by platelets, many of which are growth factors and are beneficial for hair growth. Many are involved in new cell growth, as well as being anti-inflammatory and antimicrobial. This is a slide I put in for myself to remind me that a lot of people talk about exosomes, which are new topic of discussion, and we do have our own exosomes surrounding our platelets, and so I put that slide in to remind me to mention that. They were using donated exosomes for several years. The FDA shut that down, so really the only way you're going to get exosomes is through your own PRP. Is OPC, which is optimal platelet concentration, better? And that talks about the concentration of the platelets. What makes PRP better and work sometimes and not others? And this was a question we raised within our practice several years ago. And with our own research and our own investigation of different types of PRP systems, we found that the truth is, in this study, have shown that to grow and maintain new cells, new hair cells, including hair, you need new blood vessels to be formed. The nutrients need to be brought to those cells. And if you don't have the new blood vessels, you're not going to get the benefits. And so there is a minimal amount of platelet counts that are important and therefore optimal for that concentration. You need to increase the concentration of the platelets 5 to 10 times within the PRP solution to get full benefit. And so there was a recent PRP study which was presented at the conference, where they did show that even with lower PRP concentrations, you do get improved hair growth. The platelets do carry all those growth factors and all the beneficial exosomes to the hair follicle. But if you have the higher, most optimal dosage and concentration of platelets, you had a greater effect on hair density. And it was demonstrated in this study. And so we actually have been utilizing techniques so that we can do platelet counts so that we get you to that optimal number with the hope of getting a better result. And we think there's some truth to that. A lot of people ask me about PRP versus PRF versus PRFM. It's just a terminology of different types of platelet solutions that can be used for quote unquote cell regrowth. Bottom line is there was some discussion of this at the conference, but in fact, platelet-rich plasma, or just the PRP, is probably better for hair. The other two forms, the PRF and the PRFM, actually provide what's considered like a matrix, or an area where the cells can grow. But in fact, in terms of dermatology and particularly hair, you probably don't need that matrix. You need the solution to actually diffuse around the follicle. So the bottom line was, at this conference, it was felt that the PRP is still considered the best for hair. There are places out there that are doing PRF and PRFM, and I don't recommend it, and we stay away from it. So hopefully that answers some questions for some people. Again, the exosomes, these are sacs filled with they're microvesicles filled with proteins, DNA, RNA. They have their job actually is meant to communicate between cells, but we know that exosomes from stem cells in certain parts of your body have hundreds of growth factors which can stimulate growth. These are considered to be used in regenerative medicine. There was a push to utilize donated exosomes for a variety of regenerative procedures. Some people were using it for hair growth, but in fact, the FDA shut these down. People still are asking us about it, but it doesn't exist. The only way you're going to get your own exosomes is through your own PRP solution. So it's considered an autologous exosome, meaning your own, that is surrounded the platelets, and you do get some of those with PRP treatments. And, you know, in fact, they don't even allow the exosomes, they don't allow topical exosomes to be used with laser, because the laser can then cause them to be absorbed. It's not considered safe. The question is, where are these exosomes coming from? That's why it's best to stick to your own. Lastly, the one last thing I want to talk about is hair stem cell transplants. I'm not talking about hair transplants. I'm talking about they're actually doing some new research where they actually remove follicular units from the healthy scalp. They are able to treat them, and they get your own stem cells harvested and then injected into those areas where it's needed most. So they take the stem cells away from the areas where it's not needed and you put it where it is. The studies that were demonstrated to us showed that there was an increase in hair densities. This is a very new topic. It's not anything that's being done regularly anywhere. But again, it's another procedure down the line where they may be able to use your own stem cells from your own hair in the areas of your scalp where the hair is stronger, and then just inject those stem cells, not a hair transplant, but just inject the stem cells. I want to talk a little bit about scalp health, because we're seeing more and more women come in with really inflamed and dry, scaly scalps. And there's some treatments out there to clean the scalps, which for us is very important. This hydrodermabrasion is almost like facial dermabrasion, but it's used for the scalp to clean and exfoliate. You can use it to also infuse some solutions, which can be healing to the scalp. Some people are using it to inject minoxidil with this hydrodermabrasion machine. We have a similar thing here. We do use our jet peel machine to do a scalp detox. Again, the high velocity cleans the scalp, gets rid of all the dirt. We infuse it with hyaluronic acid, a healing aloe, reduces flaking, reduces flaking from psoriasis and eczema, and allows the scalp to be clean to better absorb topical treatments. We do this treatment before we do PRP, because it's important that the scalp is able to absorb the treatments that we're giving it. So there was a question raised, do these scalp treatments, do these scalp microdermabrasion treatments disrupt the scalp microbiome, which are the normal healthy bacteria that live on your scalp? We don't want to disrupt microbiomes. We have them throughout our body. Everybody's heard a lot about the microbiome in the gut, but there is a microbiome on the scalp as well. Important bacteria which are utilized to keep the skin healthy. So there have been some studies done which initially say that it does not seem to interrupt the microbiome, which is important, because when that balance is disrupted, it can lead to an unhealthy scalp and potentially hair loss if it gets bad enough. I do want to talk about scarring alopecia briefly. We probably should do a whole webinar on scarring, because the incidence is increasing and we get more and more questions. We're seeing more and more women walk through the door with scarring. It used to be, less than 5% of our population of patients, and we're probably up to 15–16% now, especially in the last few years. Scarring alopecia can be heartbreaking because it can cause permanent loss. It is on the rise. There's no question. At the meeting, everybody was talking about the fact that we're seeing more and more of these scarring alopecias. There's probably a genetic and environmental reasons for it. The hair follicles are actually destroyed or disappear if it's not treated early enough, and it can be permanent. These are the three most common types of scarring alopecias, although there are more, but these are the ones that we see primarily. And treatment can be challenging. It has to be aggressive. It has to be multifactorial. This is a list of some of the things that are being used and have been used for quite some time. Some new things that are important to talk about is, again, the laser therapy. The low-level laser therapy has that anti-inflammatory benefit. Naltrexone is a medication that we use here. It is an oral medication. It is strongly anti-inflammatory. These diseases are autoimmune disorders, which are more common in women than men, and it requires a multi-tiered approach to get the inflammation under control to save hair follicles. We do use oral or topical minoxidil. That's also a newer treatment for scarring, because again, if we can get the hair around the scarring areas to grow, it will provide density. There's a new topical solution that's being touted. It's a combination tacrolimus clobetasol minoxidil solution. Again, for scarring alopecia, just simplifies treatment. It's a one treatment a day. The lasers are being used, the eczema or YAG lasers, which again were listed in that list that I gave you. Topical JAK inhibitors are being used for LPP. Those JAK inhibitors are primarily used for alopecia areata, but this is a topical treatment. There are no oral treatments of JAK inhibitors for scarring at this point. That may change in the future. And then PRP has been found to be beneficial in combination with standard therapy for scarring alopecia. But this is a difficult entity to treat, and it needs to be treated aggressively. There is some suggestion that there's some metabolic influences, that there's some kind of metabolic dysregulation in many forms of alopecia, mildly and androgenic, but more common in scarring alopecia, particularly CCCA. That's where the treatments of metformin and pioglitazone are being utilized. These are medications used primarily for diabetes, and they do seem to have some help, but only in a very few patients that don't respond to more standard treatment. Here's the big question. Do the GLP-1 inhibitors work? Those are diabetes medications. That's your Ozempic and your Wegovy. And there is some thought that it may actually help some scarring, which is interesting because we do see a lot of shedding with these medications. But when it comes to scarring, they may actually have some benefit. CCCA, again, a metabolic component. 37% of these patients have diabetes. There's an increased incidence of the metabolic syndrome, which is a pre-diabetic syndrome, and strangely, some increased incidence of uterine leiomyoma, which fortunately are benign growths. These are uterine fibroids, and there can also be an increased incidence of breast cancer, which is heartbreaking. Topical metformin does seem to help. Again, this is a medication that's typically considered for diabetes, but it does seem to have some benefit. And we don't know why, but insulin does have an anti-inflammatory effect, but of course we would never use it except in our diabetic patients. Alopecia areata, quickly, the big news for alopecia areata is that the new oral medications. Many people, it's just a coin-shaped lesion, multiple circular lesions, but it can progress to diffuse loss throughout the scalp, the eyebrows, the eyelashes, and all over the body. It is an autoimmune disorder and affects almost 7 million people in the United States. The new medications are called JAK inhibitors. They're recently FDA approved. They're only utilized for patients with severe alopecia areata who have greater than 50% of loss. Works best if the disease has only been severe for less than 4 years. Once we get beyond 5 years, they don't seem to work as well. Interestingly, I just mentioned that the topical applications of JAK inhibitors do seem to work for lichen planus pilaris, but they don't work for alopecia areata. It's unclear why. More research needs to be done. These are new medications. There's 2 that are available, baricitinib. It does improve in 50% of patients. Again, these are the most severe patients. And then this newer one, which is ritlecitinib, which is just recently approved. There's 30% improvement at 1 year. This is what's being utilized for teenagers. The baricitinib is really only for adults. These are new. They have a lot of potential side effects. They have to be monitored carefully, and really only in the most severe cases. I want to finish up. We went a little bit over, and I apologize. Allergens and skin irritations. We are seeing so much of this to the point where women are coming in with their scalps totally inflamed. It looks very similar to scarring alopecia. It can be very deceiving. Sometimes the biopsies themselves, we see a variety of inflammation going on. And the reality is that skin allergies and inflammations are very common. We expose our skin and scalp to so many chemicals, so many fragrances, so many ingredients. If you ever pick up a bottle of shampoo, and I read the ingredients and I'm like, what are all of these for? In truth, many of them are very irritating. And if you have sensitive skin, it can create significant inflammation to the point of hair loss. We've seen it. People can be allergic to metals, to hair dyes, to preservatives, to fragrance. The fragrances are a very common cause of irritation. And many shampoos and conditions, hair gels, we see all these chemicals. Propylene glycol in the topical meds. It's in topical minoxidil that you buy over the counter. It has propylene glycol. Very irritating. Chemical sunscreens can be very irritating. There's a lot of debate about whether they can aggravate scarring alopecia, but it doesn't really matter because they're irritating. So the recommendation is to stay away from chemical sunscreens and to really only use zinc oxide. And that is my strong recommendation. I have ridiculously sensitive skin. The only thing my skin tolerates is plain zinc oxide. for sunscreen. If there's chemicals in there, and actually if the zinc oxide is in nanoparticles, it can be absorbed through the skin. You don't want that. You don't want chemicals absorbed through your skin. Make it simple. Wear a hat and put on some zinc oxide. Again, if someone comes in and their scalp is irritated and we're concerned about scarring, if they have severe seborrhea, if they're not getting better with standard treatment, people need to get skin testing done, allergy testing, patch testing. And a lot of times multiple allergies will show. And if they're eliminated from their shampoos, their conditioners, their styling products, their facial creams, a lot of the irritation will go away. It's very common. This is my final comment. And again, I apologize for going over. This is actually a very important update. The FDA is in the process of banning all chemical hair straighteners, including relaxers that include formaldehyde. And it was supposed to be done in April. The banning was supposed to be in place at the end of the month. It has been delayed. Nobody knows why. There's a fair amount of anger about that because the study done in 2022 showed that women who use these chemical relaxers on a regular basis have a 3 times increased risk of uterine cancer compared to women who don't use them. The problem is that the chemicals that are used for relaxers and these straightening perms and the keratin treatments and even some of the quote unquote Brazilian blowouts will release formaldehyde in the process of the relaxing. And formaldehyde is a toxin and it is a carcinogen. And so it needs to be banned. It's going to be problematic for a lot of women who utilize these products. What will be used to substitute? Hopefully there'll be other safer alternatives, but hopefully that ban will be in place shortly. I have gone over and I apologize for that. There's a lot of information here. We will be posting the webinar actually on YouTube probably tomorrow or the next day. It will be on our website probably Monday or Tuesday. So if you want to go back and look at things that I might have rushed through, there's just so much happening in the world of hair loss now. And it's just so exciting because when I started doing this 15, 20 years ago, we had minoxidil or a hair transplant, which in some women can be very useful, but in the majority of women is not necessary. When lasers came around, I was very excited, but a lot of people wouldn't use them because the research didn't support it. Now the research is there. We have so many other alternatives. It's heartbreaking when I see women come in late for treating their hair loss because for all cases of hair loss, regardless of the diagnosis, early treatment can save hair follicles. And you need to be aggressive and treat early and treat multifactorially. So again, I apologize for going over. There's a lot here. I probably will be doing a separate webinar on scarring alopecia. It's a smaller population of people who would be interested, but that's okay. It's really important. I'm not going to get to all of the questions. And I think what we're going to do is I'm going to ask you to put your questions in the Q&A. We're going to leave I'm not going to shut down for a while. If every question that's in the Q&A, I'm going to respond to and get back to the group as a whole. So I will respond to all of the questions that you post there, and we will then send them back out to all of you within a week. And so I just don't, I've gone over, I don't want to go any later. I thank you all for joining us. Again, you can see there's a lot going on for treatment of hair loss. It's exciting. The number of conferences and lectures that were available at this last meeting was just really exciting because there hasn't been a lot, and it's just growing and growing and growing. So more research, more things to treat hair loss with. And we're very excited that you joined us tonight. And again, I'll leave the webinar up. I won't shut it down. Please put your questions in and I will answer them. We'll get them back to you probably within a week. So thank you for joining us. We'll keep you updated on anything that's new. Thank you.